Hello, everyone around the world. I am excited to give this presentation at SCONA 2022 virtual conference. I would like to thank the entire organizing committee for putting together this conference. Today, I will be presenting our work based on an analytical method to identify sites of greatest nasal obstruction for surgical correction in patients with cleft lip nasal deformity. This work is funded by the NIH National Institute of Dental and Craniofacial Research. This image shows nasal flow streamline in a normal nasal cavity. Here, we see flow streamline in a subject with nasal airway obstruction. The obstructive site is limited to one region. These other images show flow streamline in two subjects with cleft lip nasal deformity. We see extensive obstruction affecting multiple sites. The motivation behind this project is due to the following scenarios. You have a patient with nasal obstruction and her reported quality of life score prior to surgery was 85. Her corresponding CFD computed nasal resistance value is also shown. Here is what the patient looks like after surgery. Both patients reported quality of life score and nasal resistance values reduced significantly, indicating an improvement in surgery and also showing that surgery was effective. Notice that a high quality of life score signifies increased nasal obstruction, while a low quality of life scores indicates improved nasal outcome on improved nasal patency. Below is another patient with a before surgery patient reported quality of life score of 65 and the corresponding nasal resistance value. After surgery, this patient looks like this, but her patient reported quality of life score did not change much. There was also a marginal reduction in nasal resistance. This suggests that surgical correction for nasal airway obstruction, even among non-cleft patients, it's not trivial. In the case of cleft lip nasal deformity, we know that there are cleft-induced sites of obstructions covering multiple regions. It is not clear how each of the different sites of obstructions impede nasal respiration and the respective magnitude of nasal obstruction. The question is, can we objectively identify the most relevant obstructive sites for surgical corrections that will result in the best patient outcome? To this end, we developed an analytical method for identifying the most relevant sites of greatest obstruction. First, we ran a CFD airflow simulation in the obstructed airway, oftentimes considered the before surgery airway. Next, the airway is divided to create a grid-like structure such that each cross-section looks like this. We would then calculate nasal resistance values at all the segments which are pretty much those segments shown in stars. To determine if a unilateral segment is a site of greatest obstruction, that segment has to be greater than 3 times the unilateral airway resistance. In this case, I represent the vertical cross sections going from 1 to 20, and J represents the different regions, the superior region, middle region, and inferior region. While K is the unilateral side, left side or right side. Once again, here is a good outcome case we presented earlier. This is a soft tissue graphics of the patient's septal wall, with the green region showing the actual region surgery was done. Here is the more obstructed side of the nasal passage, showing the grid-like structure we created. The red outlines are identified sites of greatest obstruction, and the table below shows the resistance value at every segment. The highlighted regions are the identified sites of greatest obstructions in the table. Both figures show a good agreement between the green region surgery was done and our identified site of greatest obstruction. Here is the bad outcome we presented earlier. Again, the soft tissue graphics is the patient's septal wall with the outer region surgery was done, represented in green. Here is the grid-like structure of the more obstructed side of the nasal passage, and the red outlines are identified sites of greatest obstruction. Both figures show that the green region surgery was done did not track very well with our identified sites of greatest obstruction. This could be one of the possible reasons, amongst other reasons, why maybe this patient outcome was not great. We then applied our algorithm to a patient with cleft lip nasal deformity. The left side is the cleft side, as indicated by the arrow. Here is a CT image of the same patient. As indicated by the red outlines, the identified sites of greatest obstructions are along the middle segment and from the middle to posterior region of the airway. This corresponds to the region of septal deviation as shown on the CT image in red outline. On the non-cleft side, the identified sites of greatest obstruction are along the inferior segment. This corresponds to the region where enlarged inferior turbinate. This corresponds to the region with enlarged inferior turbinate, as shown on the CT image in yellow outline. Using the information we obtained from our identified site of greatest obstruction, we created the following virtual surgery models. ITR, which is inferior turbinate reduction on the non-cleft side, is shown by the green outline where the turbinate was reduced. AS is anterior septoplasty. Again, in that graphic, we see the green region where anterior septoplasty was done. And PS is posterior septoplasty. The green region shows the extensive region posterior septoplasty was done. We also created additional virtual surgery models based on the combinations of ITRO, AS, and PS. These models were meshed and airflow simulations were conducted in every airway, every virtual surgery airspace. This plot shows their respective resistance values for bilateral nasal resistance, cleft side nasal resistance, and non-cleft side nasal resistance. ITR plus AS plus PS had the best outcome, but this surgical combination is the most complex of them all and may not always be recommended by surgeons because of the high risk involved in performing this surgery. A safer alternative may be AS plus PS, where only the septum is fixed. So in AS plus PX, we see that only septoplasty is done. And whereas the bilateral resistance is a little bit elevated compared to ITR plus AS plus PS. We see that one, the complexity of this surgery is lower than doing all three different procedures together. And two, the resistance values, were closer to each other. The cleft side and the non-cleft side are closer to each other. There's not a great asymmetry in those values. This result shows percent change in resistance from the pre-airway for each virtual surgery model. ITR plus AS plus PS had the greatest change from pre, but may not be the best option for every surgeon. So the surgeon has to decide which combination they feel comfortable doing, given that most of the different virtual surgery combinations showed improvement from the pre-surgery airspace. In conclusion, we have shown a preliminary analytical method to identify sites of greatest obstruction for surgical correction. And we use virtual surgery in combination with identified sites of greatest obstruction to determine nasal outcomes for different procedure types. And based on the decision making of the surgeon, in addition to the information we present, the surgeon can determine the particular surgical combination they feel comfortable doing. Thank you.